Well, good afternoon, everyone, and it's my pleasure and honor to be here with you this afternoon. And talking about introduction, I don't know how many of you remember when you came to your first FCCM meeting. I remember very well because when I came, I didn't know no one. And then I came with someone that knows a few people, and then the introductions. Then the first introduction say, you know what, I'm the head of the ICU of the Methodist Hospital, being the head of this hospital for many years. The ICU is more than 100 beds, and the hospital is more than 800 beds. And then the other person that also I've been introduced at that time says, you know what, I am the head of the Florida and work in Florida in a hospital, a big, huge hospital, and in charge of the mechanical ventilation laboratory. And I was thinking to myself, what am I supposed to say? I just came, I just moved to Belize to take a challenge to run ICU in Belize. And then I found Janice Zimmerman, who, since the time I met her, she basically, I can call her my mentor. And this is one of the reasons I'm here. And the other guy I met is say, you know what, I'm in charge of the general ICU at Michigan Hospital. I'm in charge of this pulmonary critical care, the pulmonary lab, and it's Bob Hizzy. And of course, Edgar Jimenez. People that, through my career, I think so they are responsible why this afternoon I'm here and have this opportunity. Thank you, Janice, Bob, and Edgar. And then I was trying to brief you again what is happening in Latin America. And I think so now I can say that I've been doing a lot of work. Thank you for all the support I'm receiving from you guys. And first of all, I don't have any conflict of interest. And then let's take a look what is going on in Latin America. Of course, we need to know that at this point, there are more than 7 billion of people living in the world. And Latin America is just a small part of this 7 billion. This is the distribution of the region of Latin America. I need to mention that also we have the Latin American Caribbean that is composed by Cuba, Puerto Rico, and also Dominican Republic. And we have the English Caribbean countries that, of course, there are no part of that. Some of our countries now are becoming part of the Central American Consortium of Intensive Care. Then, this is the population of the Latin American region, and we represent 8.6% of the world population. And from this 8%, of course, Brazil and Mexico take the major percentage of the population. And as you can see, Belize is one of the smallest countries. And that way, today I say I'm talking about the big brothers, like a family. And we need to remember and go back to the 1952 when we have the Copenhagen epidemics about poliomyelitis, and then the first patient that was ventilated manually at that point. And you need to see the date, 1952. You can say now we are in the 21st century, the age of technology, and we're supposed to be able to already have this technology available everywhere. However, this is not the case. We're still seeing those pictures. This is just taken November 2014, and you can see the students ventilated manually at the same time simultaneously 2 patients. And this is in our region. It's not in other countries. It's a big country. I don't want to mention the name. The access to medical technology is a problem. A mechanical ventilator in our region could be a decent model, probably around $19,000 to $25,000 US. Plus, you need to think about the monitor, the infusion pumps, the personnel. And that's why we still having problems 63 years after. We're still having those images. You can see this emergency room full of patients and the students. You know, in Latin America, if I ask probably today, how many of you have a ventilation shift or dialysis shift? I'm sure everybody is going to raise the hand, because most of us, it's part of our training as a medical student to have ventilation shift or dialysis shift. And we're still seeing these images. Unfortunate. The ICUs, some of the ICUs in our region, but despite the fact all the constraints, also we are making some progress. Of course, I've been able to present several pictures of the different countries. I will just choose some, just to show that despite the fact all these difficulties, we're also making some progress. And of course, the question is, this is the 21st century, the technology era, and we are still facing problems to access the technology in our countries. This is our ICU in Belize after 12 years. Thank you for the support of everyone of you. And this is ICU in Costa Rica. Very nice. They have many capabilities in the region. In Central America, we have capabilities of do transplant, heart transplant, lung transplant. Kidney transplant, of course, is one of the most popular because, of course, the epidemiology. And then that's definitely, we need to ask ourselves and trying to remember how we define health. What is health for you? And of course, when we visit and try to review the different health systems, what is the best health system? Is the health system in Argentina the best for Brazil or the best for Belize? Probably no, because we have many differences. There are many differences. Patients are different. The way we do things are different. The government, and there are many issues that I will try to point out while we are in this conversation. But now, the most accepted definition of health is that the World Organization says in 1984, and the health is not just the fact that we need to be healthy. It's basically a more complex definition. We need to take in consideration what are other aspects in terms of the access to health, access to resources. I mean, it's more a broader definition, and then it's not only the absence of having a disease, being ill. And of course, we need to measure in a way to another all those things, and we use indicators, and we are going to review some indicators about what is happening. And I try to summarize a few main objectives of our health system to try to, and the main is trying to improve the health status of the population. Of course, we need to make sure that the people have access to universal health, provide financial protection, but also we need to assure that we need to offer quality of care, consumer satisfaction, and be efficient with the few resources that probably we have available. Those that probably is something looks like a dream, but this is the thing that we are fighting every day with our patients. Then we have the Millennium Goals. We are in 2015, and in the year of 2000, the World Health Organization probably embarking on one of the most ambitious programs to try to first eradicate extreme poverty and hunger, achieve universal primary education, promote gender equality and empower women, reduce child mortality, improve maternal health, trying to combat AIDS and other diseases, ensure environmental sustainability, and develop a global partnership for development. Unfortunately, most of our countries are going to be unable to achieve those goals. But it's like a very ambitious program. And of course, we are making progress. There are many of those goals that definitely we are moving forward, but still a lot to do. Of course, that's essentially say that our health systems are too complex. We need to try to see how we can have the global governance in order. There are many players, and we need to try to put this in a plurality and trying to agree in things for our patients. Of course, there are a lot of funding that is needed, and the funding that is available, we need to try to optimize the way we use it. There are numerous non-health related factors that also affect outcomes in those aspects of health. And of course, the individual behavior that also plays an important and critical role in outcomes, and is, of course, influencing the way how we are going to achieve those results. Also, we need to measure outcomes and trying to have more information, more data. And that's probably one of the things that down the road I'm going to mention what we are doing in Latin America to try to collect information and trying to present to you guys what we are doing, how much we are progress in Latin America. The private sector in our region plays an important role, and most of the time they are not being part of the discussion. And of course, we need to try to have more discussion and more people involved. And market failure in insurance markets mean there are many factors that contribute to have a good health sector moving around for our people. Finally, the cost of the financial protection. Of course, we want to have the best technology, but I always say, I would love to have the latest mechanical ventilator in my hospital. I would love to have that, but we can't afford it. Then we definitely have mechanical ventilators, equipment that is based on our needs. And I always say it, you can drive a Mercedes-Benz with all the nice features, and it will drive you nicely to the point you want to go. But also you can have a more probably decent car. It's going to take you more time, probably more uncomfortable, but it will take you to the place. And more or less that's the way I try to explain to people that when they ask me, what should be the best ventilator or what should be the best equipment to buy for my hospital? In other words, it's very complex working in a public health sector. But I think so it's doable. All of us that are here, we have the desire to have a better world and offer a better service for our patients. The Latin American and the Caribbean region demonstrate the greatest disparities in income compared with other socioeconomic determinants of health, and also compare with other countries. And yes, I'm there. I'm the small brother talking about the big brothers in Latin America. And as you can see, everyone is dressed the same. But we have huge disparities. There are many things that definitely make us different. But one of the things that is making the difference at the end is that all of us are working in partnership and in an effort to collaborate each other to move forward our health system. This is a nice picture in Panama, as you can see. It's a huge disparity in Latin America. But of course, the distribution of access of health among different socioeconomic groups follow patterns that place the most vulnerable groups in situations that continued and growing disadvantage. Of course, those that have less always have more difficulties. And the idea is to try to change that picture in the best way we can. But not everything is bad news. National health statistics in Latin America have shown a tremendous improvement compared with 50 years ago for almost all health indicators, including life expectancy, infant mortality, the incidence of all communicable diseases and vaccination that covered to mention some examples in the area that we are making progress in the health. And the three leading causes of death in Latin America, as is being demonstrated with the ICON study and also with the EPIC-2 study, that are more or less the same type of condition that we are seeing in our ICUs: ischemic heart disease, cerebrovascular disease, and diabetes, based on the World Health Report in 2014. And this is more or less we can compare what happened in 2000 and 2012, and you don't see too much difference. I mean, I think so we need to, of course, we are getting old. The life expectancy improves. We are seeing more older people in our ICUs. And this is probably one of the examples of that. I will show in some slides what is that picture. When the demographic of South America, as you can see, Brazil is is one of the biggest countries in the world. It's the 5th largest countries in the world, and of course, it represents by far a huge amount of population compared with other countries in the region. In Central America and Mexico, you can see Mexico is the 11th largest country in the world, and of course, Belize, the smallest one. And of course, as you're just seeing that picture, you can say that the health systems are not similar, and the way we provide services in our countries is, of course, it's different because we have different size of populations, we have different mixture of populations, and the size, and it's impossible for us to be able to cover those or have similar systems and effective systems. The life expectancy at birth is based on the World Health Organization report in 2014 shows that we are getting better. We have the chance to live a little bit more. And one of the things, among sex, the female group, the woman group is an average. They live 4 years more than us. Look like you are the strongest sex compared with that, no, based on that report. And this is the life expectancy in our countries, we call it the COSECATI countries. Then the main cause of mortality, one more time, we can see 47.83% of deaths on the Americas are due to 10 causes, and 7 of those are essentially based on responsible for chronic diseases that we already mentioned. And in the woman population, 3 of these causes are related to chronic diseases, and for men, 2. Just to give you a picture of that. Then, who is sourcing our health system? Our health system in the region has been sourced for many ways. Of course, we have the private sector, we have the territorial government, we have out-of-the-pocket, we have the private prepaid services that probably are the less, and also we have the social health insurance, social health programs that are covering for some of the services. Expenditure of healthcare per capita. One more time, we can see we have a huge difference in countries. We have in terms of population, in terms of the demographic and the type of population. Then you can see that also there are a huge difference among how the public sector in different countries see and invest in healthcare. This is for South America, and this is the health expenditure for countries in the COSECATI area, as I already mentioned. This is just to put a graphic. You can see the Argentina there and Uruguay, they are spending more in health. And you see, and probably that's also, we need to ask ourselves, is that invest more money is going to give you a better health? And there are many reports that say no, that it's not the amount of, if you invest huge amount of money in health, it's how you are going to invest the money that is going to make the difference. Then we have we already saw the picture in 1952 when we start practically seeing and they develop the ICUs in those countries. And of course, we are behind. We're trying to learn as what the huge countries are doing, and we're trying to bring those ideas and trying to adapt it to our countries. And we have, you can compare the born of the ICUs in the region, in Argentina, in Colombia. I acknowledge this information was provided by Dr. Edgar Celis from Colombia, and also Dr. Daniel Cerazo. And this is the COSECATI countries, and you can see Cuba, and also the rest of the COSECATI countries. Some of the English Latin American countries like Jamaica, Trinidad and Tobago, Barbados, they are joining the COSECATI region, and hopefully they are going to be officially part of the COSECATI in the following months. Beds for ICU. We just see Brazil. Brazil, they conducted a study, the census study, a few years ago. And they have already like 25,000 beds available for ICU, compared with probably Bolivia and Ecuador that I run in 150 for the entire population. I mean that it's also a huge difference, but if you say 25,000 and a little bit more beds in Brazil, but you need to also remember the size of the population. And then we are facing with other problems that we will mention in the following slides, the shortage of intensivists in our countries, the shortage of nurses, and many other factors that plays a role in that. This is some of the overall characteristics of our ICUs in Latin America. Most of them are government and most of them are closed ICUs. Majority of them are general ICUs, and in some countries they can have ICUs, specialized ICUs for oncology, for neuro ICU, for oncology ICU, pediatric and neonatal ICU. And then based on that, how the mortality is being impacted? It's a huge difference in mortality. And of course, we need to have data. And we have the two studies. We have the EPIC-2 study, and we have the ICON study that allows us to compare what happened with mortality in the region, compared with all the world. In this study, 75 countries, more than 1,265 centers, a total of 14,414 patients was of course, was a one-day study conducted to see what is the mortality in the region. And we can see that we have this is our region, Latin America, and compare with North America. And we need to think that probably there are many reasons for that. In North America, talking about Mexico, United States and Canada, there are more ICU beds. We have problems with beds in our region that also, and many other aspects that influence the way we practice. But we have champions in Latin America. And if you see, compared with the European region, it's not really a drastic difference. Of course, we have New Zealand and Australia, and probably the protocols of admission are more strict, and they don't take everybody into the ICU, just to have an idea about what is happening with mortality. And then we need, after that, also we need to see what is the tendency of the specialty in other regions, what other countries in Latin America are doing. And then Puerto Rico is part of COSECATI. And they do the challenges in critical care medicine. An overview in Puerto Rico, this paper was written by Dr. Gloria Rodriguez and his colleagues. And just to see exactly who is running the ICU, and as you can see in the paper, it's a little bit difficult probably to see, but just 16% are run by intensivists, despite the fact that many studies already shows that having an ICU run by intensivists impact mortality tremendously, and also the use and consume of resources of probably 60% in hospitals. And despite of that, now the good news is that in Puerto Rico, most of the ICUs are run by intensivists, and I believe, hopefully, in the future, that should be is our goal in the region. Before I show this slide, I want to ask you a question. If your son is just to decide, Dad or Mom, I want to be an intensivist, and I want to ask you to raise your hand. How many of you advise your son to be an intensivist? Rate is less than 50% of the hands. Meaning that the study that I want to show is basically saying the truth. The Uruguay Society of Critical Care noticed a few years ago that it's a problem to do an intensive care as a career. And myself, when I asked my professor, hey, Jorge, what do you want to do? I want to be an intensivist. And they say, you're going to definitely be in trouble because intensivists don't make money. And this is the perception in Uruguay. You can see that some of them say that the specialty definitely is in trouble. When they ask the question among themselves, if they advise the son, so his kids to run intensive care as a career, 51% say that it's a good decision, 40% say it's a bad decision, 6% say it's a very bad decision, and only 4% say that it's an excellent choice. I mean, that also is a problem in perception even among themselves. We need to try to move forward and trying to make some changes in the way we are practicing. Type of intensive care, we already discussed that. We have most of the ICUs in Latin America are closed ICU. Most of them are general ICUs, and we have some countries, huge countries, that they have specialized ICUs. Research and publication. Most of the time, we say we have problems to get data from Latin America. But this is changing. This is changing a lot. Now, with that idea, Dr. Sebastián Ugarte and Dr. Carmelo Dueñas from the Pan American Federation of Intensive Care say, you know what? Let's try to get together. Let's try to form a group among all the countries in Latin America. And this is the LACTIN group to try to create data, make research, and trying to conduct studies in the region to see what is happening with our population, especially in ICU. And now there are at least 1 or 2 studies going on, and hopefully you'll be able to see the data in the following years. We have the Latin American Sepsis Institute in Brazil that is run by Dr. Machado. I think so probably she's in the audience. That essentially is trying to teach people how to respond to sepsis, especially in the region. The Pan American Federations also have guidelines, developing the guidelines. And again, because the region is so different, we can say we need to have guidelines that are essentially adapt to our needs and also to the resources we have. Just recently, the American Society of Critical Care asked us, and I'm glad to be part of that. The FCCS Tropical, that is, most of the chapters are written by our Central America colleagues, and also under the guidance of Mario Baldesseri. He was very kind to help us help us to write her experience in some of the areas. We also have some courses that are dedicated to the obstetrical critical care support, along with the Pan American Federation, and hopefully we are going to incorporate all those resources to our armamentarium in the Latin American region. We are also one of the greatest initiatives, and I commend Dr. Sebastián Ugarte on that, is that since a few years ago he had the great idea to invite leaders from all the Latin American countries to write chapters for books for our region. And with a great acceptance, just Right now, we are finalizing pharmacology on intensive care. Most of the chapters are reading from Latin American leaders in that area. I mean that it's a lot of information. There are good news going on in Latin America. Not everything is bad. And hopefully, as we are having those spaces open for us, in the near future, we're going to have more information about what is happening in our region. Of course, we are discussing with curriculum competence and trying to see, trying to organize and define what is the intensivist curriculum in the region. And it's a great initiative that is starting also in the FCCM with Judy Jacobi. She's trying to see how we can create a competence. And each country, of course, has its own competence, but we're trying to standardize the way we practice the specialty. In most of the countries, our background is internal medicine, surgery, and also anesthesis. And then we do the 2 or 3 years for intensive care. Who runs the ICU? In our countries, again, we have a shortage of intensivists. In some areas, and we will love that in the future we have most of the intensive care units run by intensivists, but it's not the case. We have cardiologists, pulmonologists, anesthetists, and internists in some areas because we need at some time we need to cover the time in the ICUs. But our main goal is that in the near future, all the ICUs will be covered for intensive care doctors. I ask, and I want to acknowledge all the societies. I send a question. What is the main challenges that you're facing in your country in the practice of intensive care? And of course, the main problem is the shortage of intensivists. Access of technology, we already discussed it. We don't have all the resources that we would like. And of course, the compensation. The intensivists are not being compensated for the time and effort they spend in ICU, and standardization of competence. Those are, the most important challenges that we face in Latin America, and I believe in some ways the same challenges that in general the specialty is facing. And it's not a problem only for the intensivists. This is an article published in New England Journal of Medicine trying to talk about what is the deficit in doctors, nurses, and midwives around the world. And as you can see in this, the health workforce burden, according with the WHO in this same article, just to illustrate what are the different areas and the different regions that we have a constraint of people. But of course, the most important thing is that we need to become organized. We need to get organized in the region and trying to move forward to move the specialty and get the best of that we can. And then with that idea, the Pan American Federation was founded in 1979, and it's a group that includes most of the Latin American countries, and also Portugal and Spain are part of COSECATI, and COSECATI as part of the Pan American Federation. This is the act of formation. And then most recently, in 2010, I remember in 2008, I went to the World Congress of Intensive Care in Florence. And at that point, I was looking at the presentations and nothing for Central America. And then I approached, at that point, Edgar Jimenez, and Edgar said, you know what, Jorge, you guys need to get organized. And then, surprisingly, because we think, oh, I'm making the effort, and then I found out that many people at the same time are doing the same effort, but separate. Then we got a call. I say, I never met Dr. Sinclair in my life and I sent him an email. Hey, Jorge, what do you think? We can get together or we can create something for Central America? And he said, you know what? Since 20 years ago, we're trying to do this effort. Then I got Dr. Sileski, and he said, Jorge, we are doing the same. But all of us are trying to do our efforts separate. Say, let's get together and create the Central American Consortium of Intensive Care. And then at that point, Edgar said, Jorge, you just tell me, and I'm going. I asked Nestor Raimondi from the Pan American Federation and say, Jorge, I'm on board. Janet Zimmerman, I'm on board. I'm on from the Society of Critical Care Medicine. And then we create that group and make the effort to bring everybody to Belize. And then at this time, it's an anecdote of this trip. Because Edgar Jimenez, when he came to Belize, he told me, Jorge, is a hurricane coming to Belize? I say, no. Always, there are threats. We have the coral reef, nothing hurricanes coming. Jorge, it's a hurricane. I have a good source. No. Then he came, we have a good night, spent with meetings, and we get together. But the real meeting for the formation is next day, Saturday at 10 o'clock in the morning. And at 8 o'clock, Edgar say, Jorge, the hurricane definitely is coming. And it's true. So you know what? Let's get the meeting going as quickly as possible. And we officially formed the society. And when we're trying to look for planes, no planes. Meaning that we need to draw Edgar to Cancun, and that way Edgar went back to his work. And I appreciate that Nestor, Edgar, and Janice make the effort to be with us. And now the consortium of Central American intensivists is growing very fast. And you guys have been very supportive to us, and we appreciate that. And then I remember in 2008, I met Mari Baldesseri in Russia. We was in a meeting, and she was very open and said, Jorge, whatever I can do to help, I'm on board. And then they say, you know what? Why we in Belize need to develop skills. There are not people with skills. And he said, I have this course that we put together with Janice, the fundamental critical care support, and then you just let us know. And this is in June 2008, 6 months later, and later Janice and Mari, along with MJ, they went to Belize and teach the first FCCS course of in Belize, and they've been very instrumental in the region to let us and grow, but provide us with the skills. We want develop skills. We don't want people to come and give gifts or equipment. We want people to help us to develop skills, and that's been probably one of the most important part of FCCM for the last few years. I want to acknowledge all the Cooper Smith, the actual president, as the past president, Chris Farmer, Pamela, Clifford, because all of them are basically in support of Latin American group. And of course, we can, when we are talking about FCCM, ignore Rosie Hernandez. I don't know if someone in Latin America say that they don't know Rosie Hernandez, because she is always for us to help us and trying to get us through to get the things we need for Latin America. And of course, Bob and Edgar will be very instrumental. In the next few slides, you will see, and I want to acknowledge Sebastián Ugarte, because he was really instrumental to help us. I want to acknowledge Nestor Raimondi. We now, in many of the countries, we already are doing percutaneous tracheostomy, thanks because Nestor Raimondi he's been willing to go and spend a few days in our countries and teach us. I want to acknowledge Daniel Cerazo. He is not with us, but he was very instrumental for the formation of this effort that we have now. And of course, the FCCM, because FCCM in the last years have been put a lot of effort. And when we ask, you know what, we want to have a symposium in Belize, we want to have a symposium in Mexico. We have a symposium in Mexico for the last 4 years, much more than 4 years. And now we are doing MCCRC in many of the countries. I don't think so at this point there are no any country in Latin America that FCCS is not a part of the curriculum. And that is basically talks about the support we are getting from FCCM. I want to thank you, Mari Baldesseri, thank you, Janice, Bob, and all of you that you are being instrumental and very helpful for us to grow in the region. And at the end of this small video, you will see in 2001, we didn't have nothing in Belize, no ICUs in Belize. Now we have more than 18 ICU beds. We have a open heart surgery program, but not because we have the resources. We have our partners, and you are our partners. And especially thanks to the Heinemann Foundation and Carolina System, because they are being instrumental in helping us, but also to bring people to get skills. With that, I would like to present the next video.
A Chinese proverb says, give a man a fish, you feed him for a day. Teach a man to fish, and you feed him for a lifetime.
told it was a 16-year-old facility, and when you drive up to the front, you're like... That's just sad.
The KFMH hospital is the only tertiary care hospital in the country, I believe. We were fortunate in being introduced to the Carolinas health system. What started out as a visit to look at general supplies and equipment for the hospital suddenly focused on us getting a cardiac cath lab. And for some reason, Dr. Robichek thought that this is the way we should go. And that was the start of it.
Everything in life is about opportunity. And I think I'm an example where if you get an opportunity, you can do a lot with it.
This is a big day. For Dr. Coy, this has been a vision that he's had. Now he's seeing his vision come to fruition. We feel very honored to be here.
I'm having to put this hose clamp on one of the water lines because one of the fittings that came with the machine does not fit on the oxygenator. And there's no time to go to the hardware store to find the piece that fits it.
Yeah, heart surgery is not that complicated, but it does require a lot of stuff and to do it right.
Someone tells you 30,000 US, they will probably never see that amount of money in one place in your lifetime. And so you're basically telling them there's no hope, you're going to go home, suffer and die. This is something that I think is unacceptable.
For the first time in the history of Belize, we have performed 2 open heart surgeries.
Thank you, Francis.
Well done, yeah. Made history. Today is the best day. It's the best day. I don't know how to describe it, but it means a lot for me because I'm so happy, you know, and I will be like free.
Finally, I would like to ask all the doctors from Latin America if they can stand up.